Well, good morning, everyone. A very warm welcome to Engaging Evidence from wherever in Australia, New Zealand, or further afield that you're joining us from. I'm Steve McDonald. I'm co-director of Cochrane Australia at Monash University in Melbourne. And it's my pleasure to introduce the meeting and chair this opening session with my co-chair, Hanan Khalil. Let me first begin by acknowledging the traditional owners of the land on which we meet. For me, this is the Wurundjeri people of the Kulin Nation. I pay my respects to elders past, present and emerging, and extend that acknowledgement to all the lands on which we are gathered. So evidence has been scrutinised like never before, putting researchers and those responsible for creating guidance and setting policy under the spotlight, and turning epidemiologists into household names. Some of the themes that were bubbling away before the pandemic have been turbocharged over the past 18 months, and we'll have an opportunity to explore these in more depth during the plenary sessions. Whether that's the rise of living evidence, the prominence given to issues of research integrity as trials and other studies are subjected to forensic examination, or having to contend with the barrage of misinformation and at times fanatical lobbying. So one of the purposes of this meeting was to bring together people with diverse interests in evidence synthesis and implementation, and provide early career researchers with an opportunity to present their work after foregoing many of the usual opportunities we're used to. So I'd like to thank the co-hosting organisations of JBI, GIN ANZ, Cochrane New Zealand, and the local grade centres for contributing so much to the programme. And we're delighted that over 150 people have registered for the event. Before we sort of get going, I have some housekeeping. As you'll have seen, we are recording these sessions and we'll make them available through Cochrane Australia's YouTube channel. Now, to get to this point, you will have come through the Oxford Abstract system. And just before we get going, I wanted to share the site with you. So obviously you've come through the program page, but the platform supports direct messaging. And if you go to the attendees icon here on the left-hand side, you'll get a sense of who else is joining us. And you can open the right-hand window and you can use the direct chat there. So anyone with the messaging icon, you can click on that, and if green dot indicates that they are active in the platform at the moment. One thing I wanted to mention, that if there are any problems with IT as we go through the event, please feel free to contact Karla Fry, who's on our help desk. So we put that right up here at the top left-hand corner of the first attendee. So back on the program page, one thing I wanted to just draw your attention to is a session that's happening tomorrow morning, which is an open meeting of the Global Commission on Evidence to Address Societal Challenges. So this is an open meeting, but you will need to register for this event separately via the link that you can access here. So the other thing is around social media. So those of you who are using Twitter or LinkedIn, please use the hashtag EE21. And then finally, for this particular session, you're able to put in chat to the hosts and the panelists, but we encourage questions to be submitted through the Q&A panel. And what we'll do is, unless there are points of clarification, we'll hold over questions until the panel discussion at the end. We can also unmute you if you prefer, ask your question in person.
Presentation for yourself.
So we're just going to get started now, hopefully. We have a little bit of an issue with our first speaker, Lai Heng, but hopefully we're going to be good to go. I'm just going to introduce you now to, or my pleasure to introduce my co-chair, Hanan Khalil, who will introduce herself and hopefully get the first session underway.
Thanks very much, Steve. And hello, everyone. My name is Hanan Khalil. I'm an associate professor at Trobe University and co-editor-in-chief of JBI Evidence Implementation. My research focuses on advancing the science of knowledge synthesis, and in particular research projects related to scoping reviews, umbrella reviews, and rapid reviews. And I'm honored to be invited to co-chair this plenary session with Steve today. As Steve mentioned, there are several challenges that the pandemic has uncovered in the last 18 months. In addition to what was mentioned, we also saw the increased number of publications of both primary studies and systematic reviews, and the multiple platforms that have been created by several global organizations such as the WHO COVID, Lead COVID, Cochrane COVID-19 Register, and the Love COVID platforms. In this session, our speakers will reflect on their experiences and share their insights on how the pandemic has impacted the roles on users and producers of evidence. Now, I would like to introduce Dr. Funk for our session today, first session. So Lai Heng is a senior emergency physician based in Sydney, who also has a passion for public health and disaster preparedness, climate change and health, Indigenous health, and the social determinants of health. And something unexpected we did discover about Lai Heng. Lai Heng was an RA supporting Chris Seligy on one of the very first Cochrane reviews that she did publish while she was in medical school in Flinders University in the 1990s. Lai Heng is currently chair of the Public Health and Disaster Committee of the Australasian College of Emergency Medicine and the clinical lead of the New South Wales Emergency Department Community Practice in COVID pandemic response. So over to you, Lai Heng.
Hi, Lai Heng. Are you able to unmute yourself?
Hi, everyone. I'm sorry about my problem with the IT side of things. I am really honored to be invited on the panel, and I would like to share with you what I've experienced so far as both someone from the clinical cold phase as well as someone with public health background. I'm going to try to share my screen. And can everyone see it?
If you go into presentation mode. Thanks.
Okay.
There's a little, the audio is a little hard to understand, so you just might need to we'll just see how it goes with the audio, but it was quite tricky to understand some of you. Yeah.
Okay. Can you hear
That's
me
better.
now?
That's better.
Okay. So I'm using not my own computer, so you just have to bear with me. But I'd like to share with you, it's sort of my joint role trying to balance clinical medicine as well as public health, which I've really enjoyed. But sometimes there are some conflicts. So just to set the context, we're 21 months into the COVID-19 pandemic. And as of November 5th this year, the number of cases in Australia was 130,000. This is in contrast with 250 million globally. Number of deaths in Australia is was approaching 1,500, whereas in the world we have more than 5 million deaths. So Australia, in a way, has been really sheltered from the pandemic in a sense, but we still really felt a lot of pressure in the second surge in New South Wales, which started end of June to currently, and the second surge in New South Wales really peaked in September, and we're now on a downward trend. But it meant that we were locked down for 107 days. In a way, COVID-19 hit us after a perfect storm of events. We had global warming and unsustainable development, and we had air travel that had increased fourfold since 1990, making traveling so much easier, and we were living global, interconnected lives, but there were also inequities that were rising in society and health systems. And I think the pandemic thrived due to a large gap between limited, disjointed pandemic preparedness in many countries and a system really unable to cope with a fast-moving and exponentially growing pandemic. I put this up because
Hi, Lai Heng. Okay, we've been already derailed by IT issues. So unfortunately, Lai Heng was having issues this morning with her Zoom. And as you can see, that's now pretty terminal. What we're going to do is we're going to flick to the second speaker and we'll play a video. So the Karla Soares-Weiser is the editor-in-chief of the Cochrane Library. She's a clinician. She holds a doctorate in evidence-based healthcare. And I caught up with Karla last week for a Q&A on the pandemic, Cochrane's response, and what lies ahead. So this goes for about 10 minutes or so. And then in the meantime, we'll hopefully try to resolve those IT issues with Lai Heng. So off we go, Shauna, thank you. I think we need some. It's exactly 2 years since. Hello, Karla. Lovely to see you. Welcome to Engaging Evidence, and thank you for joining us. It's exactly 2 years since you were with us in Melbourne for our last meeting, and my, how things have changed.
Thank you, Steve, and thank you all for inviting me. I'm very sorry I'm not going to be able to be in person or at least lively, but this is 1 o'clock in the morning my time, so we've made a compromise. Thank you all, and I hope that you have a fantastic meeting.
So we wanted to use this time to discuss Cochrane's response to COVID and the challenges we face more broadly as an evidence community. Now, a Nature article talked about how COVID broke the evidence pipeline, revealing flaws in the system that produces evidence. And thinking back to the start of the pandemic, how did you feel? Did you think Cochrane is prepared for this, or were you apprehensive about Cochrane's capacity to respond?
To me, to be honest, Steve, was a mixture of panic, responsibility, and an opportunity to demonstrate what Cochrane is about. So at the beginning of the pandemic, I think we all didn't really know what to do, but then it started becoming very clear that we had to do something. And for us was really to understand that Cochrane had what it takes. Cochrane's mission is about trusted evidence that is accessible to all. And that was really the key point to respond to the crisis. But what really made the change for me was in March 2020, when we started looking at the growing number of cases, and we started to understand that really this was a situation that would spread all over the world, and that really we needed to gather our community and identify ways that we could respond. Of course, that we knew that we had many challenges to do that. But the first thing we did was really to put together an advisory group that was international with experts in all parts of the world to really understand and see what Cochrane could do. So as an organization, we also got closer to our stakeholders to understand what they needed from us. And then it started the challenge. We drafted a plan and it started putting together a response. of course, that part of what our success was about was really the fact that Cochrane has a community of experts, content experts, methods experts, etc., that we could really leverage, and the community was really keen to work with us and to dedicate their time, many times in difficult situations. So what we achieved together showed that the importance of organizations like Cochrane that keep its independence, integrity, and really strive to produce reviews that are of high quality.
So as you'll be aware, a frequent criticism of Cochrane is that its reviews are too long and take too long to prepare. So was this the key challenge Cochrane faced, or did the pandemic expose other flaws in Cochrane's publishing model?
Just a year before the pandemic, part of my job was to put a working plan. So we had already a sense of the challenge that we would face. Cochrane Review became very complex over the years. It's really hard to consider that we could respond in such a short period of time, but we had to try. So I think part of what we've done is that we created guidance and we created a network, pulled together the questions and start looking at the community and saying, what are the key ways that we can reduce the time to produce reviews? So one of the things was to involve more people in each review. And the other thing was to provide support. So we provided support on the methods, and we provided support on the editorial process. And this really reduced the timeline. But part of us was also to innovate and to do other types of reviews. So this actually created other types of complexities that we didn't know before. We were more used to do reviews, so we had to do reviews, including one of the most cited reviews in the Cochrane Library, that at that point was based on modeling. We have never published a review based in modeling before. So we had many challenges, and I don't know, my sense is that when a community like Cochrane wants to do something, and the only thing that, what puts us together is really, we all committed to the mission. So we all knew that we had what it takes. And identifying challenge for me, it's really part of what we're trying to do to actually to put the organization moving forward. So the challenges are also opportunities going forward.
So COVID has challenged the evidence community like nothing before. I've heard the pandemic described as evidence on steroids. What's frustrated you most about the pandemic?
Steve, I think the biggest frustration was, in many ways, the lack of collaboration that led to duplication of efforts. We have seen an explosion on the number of primary research, but we also have seen, misinformation and misunderstanding of uncertainties, leading to infodemic. And this really all end up increasing the inequity and the gap between low-middle-income countries and high-income countries on the access, on capacity building, the production of reviews, or dissemination of the right types of evidence synthesis to low-middle-income countries. In terms of the opportunity, this actually led us to plan Cochrane Convenes, and this was a really fantastic moment of assessing, and we put together a group of healthcare workers, consumers, policymakers, politicians, to really look at what we've learned and help preparing for the future, when we know we need evidence, and we need to identify ways to have this evidence available in the right time for the right people and in the right format.
So looking ahead, what do you think the legacy of COVID will be for Cochrane? Will it mark a fundamental shift in the way we operate? And are you confident Cochrane will survive and adapt, ready to tackle the next crisis?
I think that we need to innovate, and we need to continue to innovate, and we have it already in our DNA. We do things in a different way. So our unique selling point has always been the fact that we update, and then every year when we do surveys of consumers of our reviews, it is clear that that is one of the reasons why they came back to the Cochrane Library. However, I think we need to also create mechanisms that this becomes pragmatic, because we can't maintain all reviews, living systematic reviews. These are resource intense. And we should be clear why a review needs to be living. We should be clear why and when a review needs to update, and why and when a review should not be or does not need to continue to update in a regular basis. So these are challenges when I say that we have to streamline our process and make our process more nimble. These are challenges that we are facing now, and we're looking at ways to make this possible. But for sure, the issue about us having already in the organization people that understood the importance of living systematic review put us ahead of the game. That's why I'm saying that Cochrane always innovated, and being ahead of the game meant that we could actually gather the community and deliver on issues that in the past we would not be able to deliver so quick. So there were a number of innovations, actually, not only the living systematic reviews. We put together a curated register, and the importance of this is that actually this is the future. There was an opportunity to look at automation of a part of the process that is very time consuming. There was an opportunity to look at how we work with the crowd, to support the process and be more interactive. And we also really worked very close to key stakeholders. So we partner with the WHO from the beginning to the end of the process, and because we wanted to do reviews that were relevant. And we knew that some of the questions, so for example, WHO came to us and said, we need a review on ways of hand washing, because in many parts of the world, soap is not an option. People use ash or other type of things. And they knew that Cochrane would be in the best place to do such a review. Yeah, it is a priority it is a priority because many people needed to know the results of this review. So the fact that Cochrane is international and could respond and have this community that knows how to innovate, to me, it was very important.
Thank you, Karla. I know this is a very busy time for you. You have lots of other commitments and challenges to deal with, so thank you very much for your time and for sharing your thoughts with us. It's very much appreciated.
Thank you all very much, and I hope you enjoy your meeting.
Okay, well, that was Karla sharing her insights. I think she found herself in a very unenviable position early on in the pandemic of having to corral Cochrane's response to the pandemic. So we are now going to have round two with Lai Heng. Hopefully the audio now is working well. So fingers crossed, and over to you, Lai Heng.
Hello, I'm very sorry about the IT problems. I hope that the sound is a bit better. I love to, when I was talking about Pakistan, and I wanted to show this slide because I was in Pakistan in March 2020 when coronavirus was just a rumor starting in Iran. And I remember I returned to Australia just in time before the border closed. So this is an evidence meeting. So I just wanted to state the obvious, look at the definition. So evidence, according to the Cambridge Dictionary, is one or more reasons for believing something is or is not true. And certainly, as a clinician, I grew up I studied medicine in the practice. But I think COVID-19 hit us in very quickly and in very unexpected ways. And as the previous speaker said, we really had to innovate. It's COVID-19 was declared a pandemic by the WHO on 11th of March, and it certainly disrupted society and exposed many inequities in our society. And in terms of evidence in medicine, clinically, we rely on evidence by our patient care, and the evidence is usually gathered, ordered according to certain hierarchy, and then we have ways in which to disseminate the evidence. And I guess the main goal for all of this is to improve patient care. However, I think it's highlighted, this pandemic has highlighted how very little attention clinical medicine pays to the social determinants of health. And as we've seen in the pandemic, those were the determinants really of how well we manage the pandemic. This was an opportunity for me to really think about what has happened so far. I have been busy working so much that really I haven't really had time to process what I've been through. And so thank you again for this opportunity to really think about what my colleagues and I have gone through. In the first wave, I remember it as
Lai-Heng, can I just interrupt a second there? The audio
Sure.
The audio is still not brilliant. I think if you move closer to the screen, we can probably hear you a little bit better. It might be better also, just in terms of bandwidth, to try turning the camera off, and see if that makes any difference. If it's not making any difference, we might just have to come back to you after we've had from Julian. So turn the camera off.
Okay.
And then speak, I think move closer as you can to the screen.
Okay.
That is better. And just, I think, keep still. And I think we might be okay.
All right. I still have the headphones on. Maybe I can try it without if I come closer to you. So I just wanted to talk about the reflections I've had. In the first wave, we had an evolving situation. And really, there was no treatment at that time. No one really.
Lai-Heng.
Yes.
I'm sorry. It's really not. It's just not audible at the moment, I'm afraid.
Okay. Sure.
It sometimes is, but then it goes in and out, and it's quite difficult to follow.
Okay. Is this better?
Yeah, I think it's consistent. That's the problem.
Okay. I'm putting the volume up. I'm hoping that it will be.
I think if you maybe if you disconnect the headphones now.
Yes, I've done that. So I hope that you can hear me better. And I'm really sorry about this.
I think because it's not very easy to follow. It just comes in and out, and it's quite tricky to follow.
Okay. I guess the next speaker could go first, and I'll try to come back to this. And I'm very sorry about this problem, and I really wanted to.
I think what we'll do, Lai-Heng, we'll go to Julian for his presentation.
Okay.
And I will. Shauna will give you a call, and we'll try to resolve that whilst Julian's speaking.
Okay. All right.
Okay. Thank you.
Thank you.
So if you could stop sharing your screen now, that'd be great.
Yeah, I'll do that.
So, wow, so much for IT issues. I'm sorry about this. Hopefully we will get Lai-Heng back on a decent, with some decent audio. So let's go to our third speaker, who is Professor Julian Elliott. Now, Julian is well known for his passion for living evidence to inform high quality, responsive, up-to-date guidelines, policies and care. And among his many roles, Julian was a driving force and the founding executive director of the National COVID-19 Clinical Evidence Task Force. And he now chairs the Australian Living Evidence Consortium. And Julian will be talking about living evidence, the lived experience. So hopefully, Julian, we're not going to have anywhere near these problems with your presentation.
Yeah, that would be bad, wouldn't it? Can you hear me? And can you see my slides?
We can see your slides, and we can hear you a lot better than we could lie hang. Yeah.
Okay. I really feel for her. I had similar issues with a presentation recently. I know how frustrating that is. So look, I'll try and move through this quickly so we have some time at the end to come back to lie hang. So thank you to Steve and the other organisers for asking me to speak today. So I was asked to speak a little bit about just experience with living evidence, particularly in the National COVID-19 Clinical Evidence Task Force. So first of all, in terms of my interest, just so you know my perspective. So I think Steve has mentioned most of my roles here. I'm a infectious disease physician at the Alfred and also co-founder and CEO of Covidence. So this model of clinical practice guideline development, I think will be familiar really to most or all of you. Really been well established now in most healthcare systems for quite some time. What of course is striking is the amount of resources and people that are required to develop systematic reviews, and then of course to develop evidence-based guidelines, particularly using the GRADE methodology, in order to achieve the ultimate outcome of better decisions and better outcomes from healthcare. And of course, one of the challenges with this model has been the amount of time and resources, and therefore the difficulty of maintaining quality, but also keeping up to date with the latest research. And so making sure our guidelines are current. In response to these challenges over several years, we've been developing this model we call living evidence. So that includes living systematic reviews, and then more recently, the development of living guidelines. So I just want to talk a little bit about the model very briefly, describe a bit about our experience within the task force, and then just a few reflections on what I think we've learned through that process. So first of all, just so everyone's familiar with the model of living guidelines, if you think of conventional guidelines, which are typically updated every 3 to 5 years, sometimes less frequently. So we always say the initial process of developing a guideline is like climbing a mountain, an enormous amount of work to get to a point where you have an up-to-date guideline developed using robust methods that is then disseminated. But from that point onward, of course, there is more and more research being produced relevant to that guideline. And so therefore the currency, accuracy, and therefore utility of the guideline decays over time until at some point there is a decision made to update that guideline. And then once again, we climb the mountain. In contrast, living guidelines certainly needs to do that initial mountain climbing. So there's no escaping the initial work that needs to be done to develop the what we'd call baseline version of the guideline. But then as we near that peak, we shift towards this living mode where we run very tight, frequent cycles of continuing to survey or search for relevant research reports, incorporate those into living systematic reviews, and then update our GRADE profiles and, if necessary, our recommendations. And so by running these very frequent, rapid cycles, we can keep the guideline up to date over time. So it's not that there is no effort required, but that effort is more evenly distributed over time. So as we often say, walking along the plateau. So with that model as the foundation, a few years ago, we established the Australian Living Evidence Consortium, which is a group of 12 organisations led by Cochrane Australia at Monash, to really push forward with this living guideline model in Australia. And over the last 2 or 3 years, we've had a number of pilot projects. The first was the National Stroke Guidelines, which were really the first national living grade-based guideline anywhere in the world, and has now been in living mode for 2 years, and I think really remains an outstanding example of living guidelines. What we've found through that, sorry, this is very small, but you can, I think, see here that in terms of engagement with the guideline, this was after the previous update several years prior, the level of access to the guidelines. And then once we started to update the guideline regularly, you can see a really quite massive increase in engagement with the guideline. And also in some survey work that was done, the blue and the orange here are survey respondents who felt that there was an increase in access and trust with the guidelines. And then following stroke, we also then moved into working with groups in diabetes, developing a very large network meta-analysis for drugs and also looking at new technologies. So these were the foundations of the living guideline model pre-pandemic. And then when the pandemic hit, we happened to be having conversations with NHMRC about this, and with their support moved quite quickly to establish the National COVID-19 Clinical Evidence Task Force, with funding from both philanthropy and government. And since that time, we've been maintaining national guidelines for clinical care of people with COVID-19. In the previous projects, we've tended to be updating every 1 to 3 months, but we're aware that both the need and also the flow of research in COVID was going to be even greater. And so we made the somewhat rash decision early on to commit to updating the guidelines every week. And certainly for the first year, that was the cadence and the frequency that we were updating. Now that we have a much more stable base of recommendations, we tend to be updating every few weeks to every month or so. So I just want to now give you a bit of an overview of how we've run that living guideline model within the task force. Again, I think just to give you that sense of the like looking under the hood and seeing how does this actually work. So this is just an infographic that runs through the process of how we develop and then update a recommendation. So of course we start as always with a question, and one of the advantages of running a living guideline model is that we can be in a conversation with end users, and we encourage all clinicians in Australia to submit questions through our website, and then those questions really shape the focus of our guideline work. So it's a very nice benefit of a living guideline model. Of course, there can be many variants of a particular question. When we have those questions come through, we feed them through to the senior clinical group called the Guideline Leadership Group, who assess and decide whether the question is in scope. This then gets converted into a standard PICO question. And then through the wonders of Steve McDonald, we have maintained, I think, a very broad but also very efficient mechanism of searching global COVID-19 literature. I wish I could tell you more details. I don't have enough time now, but it's really been, I think, a fantastic example of both rigour and pragmatism. The evidence that's identified is fed through to our internal evidence team, who use that to develop and then maintain living systematic reviews that then feed through into grade evidence profiles using standard grade methodology. And this is then presented to our panels. So we have 7 main panels, but we've also had other groups established at different times, for example, in infection control. And we also have a pool of additional experts we call the expert advisory group, who we can call on as needed to join these other groups. Those groups are also supported by an independent conflicts of interest committee. This is led by Lisa Barrow in the US, who many of you will know. It's been an absolutely fantastic relationship with Lisa and her group, who've really done a lot to support the management of competing interests within everyone who's been associated with the task force. And very importantly, a partnership with Consumers Health Forum, maintaining a consumer panel who've provided invaluable input, not only into the recommendations, but also the way that the the task force is working. So from there, the panels may develop a proposed recommendation that then goes back to the guideline leadership group. And I think this is an interesting aspect of the way that the task force has worked. I think this senior group has played a very important peer review role, and I think really has added quite substantially to the rigor and relevance of the recommendations that have been produced. So those recommendations are then reviewed by the guideline leadership group and then made a decision about whether that needs to be modified. If so, it'll go back to the panel. Otherwise, it'll move forward. And so just to note that all of what I've just described has been occurring on weekly cycles for most of the period of the task force. So for example, the guideline leadership group had been meeting every Monday evening. If it's recommended by the guideline leadership group, that will then move forward. We have a liaison group with key representatives from governments, both state, territory and Commonwealth, where we will, if we have a particularly policy relevant recommendation, share that with the group prior to our finalisation. This is for the purposes of input, particularly around important aspects of implementation that government may be aware of that is important for our kind of final considerations. And recommendations then go through to our steering committee, who are comprised of a representative from each of the 32 member organisations of the task force. And then if approved, will then be published online through MagiCap and then disseminated in multiple ways, including communiques into media, social media, through our website and MagiCap, and importantly through all of those 32 member organisations. And then once a recommendation is then live, we of course are then committed to updating and maintaining those recommendations. More recently, as we've moved more into this plateau phase, we've had a process of prioritising recommendations. So some we will prioritise and ensure that they are updated immediately new evidence becomes available. For others, we have deprioritised and will wait to see what volume of evidence is accruing before we will then go and update. So just to reflect briefly on, I think, some of our key learnings through this living guideline in the context of COVID, the task force is an organisation that is comprised of its member organisations. These organisations are the convener of the guideline. And I think for me, really important reflection is that commitment buy-in from across the health sector has been absolutely critical to everything that we've achieved through the task force. So I think, again, just reinforcing the way that stakeholder engagement and stakeholder relationships are just absolutely critical, I think, to any guideline endeavour. So as we always say, the guideline is not the text that is written, it is everything around it. And those partnerships are absolutely critical, I think, in building the commitment and the momentum behind the recommendations and giving that profile and sense of confidence amongst clinicians when the recommendations are made. I think secondly, we are incredibly grateful to all the clinicians who have volunteered really thousands of hours into the work of the task force. One of the, I think, questions around living guidelines was, is it really possible to maintain guideline panels over longer periods of time? Will clinicians really tire of this and disengage? And we have seen absolutely no evidence of that at all. Now, of course, this is in the context of COVID, but I think also in the other living guidelines, we're also seeing this. I think clinicians really value guidelines that are up to date with the latest research. They know the research, they're seeing it come through, and they really want to see it incorporated into their guideline. And I think we've seen an incredible sense of pride from our clinicians who've done all this work maintaining the recommendations. I think also then in terms of engaging with the wider community, we've done a lot of work on communications, working with journalists, a number of media outlets, and also in social media. Again, I think that's been absolutely critical to the impact that the task force has had, Not to say that, of course, that it's always been positive coverage. We've always, there are always alternative voices. My reflection would be that we are an increasingly fragmented society. And of course, many people live in social media enclaves that are kind of algorithmically driven to be exposed to a very different kind of mix of information. And I think going forward as guideline developers, we really need to think, more deeply about how we can better engage community members who are perhaps not seeing the forms of information that most in the community are being exposed to. Also, in terms of end user clinician engagement, this is some of the data from our dashboard, which we keep up to date. We've really had incredible uptake and use of the recommendations. Again, I think one of the questions with living guidelines has always been, will this confuse clinicians? Will the recommendations be changing so quickly that they kind of feel like the evidence is flip-flopping around? There's a lot more work to do, I think, in the implementation aspects of knowledge translation associated with guidelines, living guidelines. But again, both the work that we have done so far, and Tari Turner's led a lot of this, is indicating that clinicians, again, really value currency more than anything. Then in terms of trying to assess the impact of our recommendations on practice, I would say has been quite challenging. There's really very little data systems within Australia that are comprehensive and dynamic enough to be able to track practice in somewhat real time as we update recommendations. I think with the notable exception, and this is one example of data from Sprint SARI from the Australian ICU community from ANZICS, a really just outstanding observational data study, which we've been very grateful for being able to track. And then working with government and policymakers, again, I think we've found that government does really value the fact that we can be responsive to the evolving situation of the pandemic. And so again, that living guideline model has been, I think, extremely appreciated from government. And of course, within that, we have been, emphasising the importance of the independence of our work, but working very closely with the partners in government. And then just a note that we've really been struck by the discordant availability of data. So for drug recommendations, we've been able to make strong recommendations because of very large trials and a very large amount of high quality information. Whereas for non-drug interventions, which are, I would argue, as least as important, there's really been an unbelievable dearth of high quality information. So we've been very involved in the development of infection prevention control recommendations, particularly healthcare worker PPE, and the scarcity of data there is really an absolute tragedy. And so I think we've learned a lot in our work in the task force, and more broadly, I think around the world. Now we're seeing the broader uptake of these living guideline model. But I think I just want to note that even though groups like WHO are now moving into adopting living guidelines, and also NICE in the UK in their new strategy, living guidelines is one of their 4 strategic pillars. So this is definitely getting momentum. But just to note, there's still a lot to learn about the living evidence model, both living systematic reviews and living guidelines. So an enormous amount of research that we still need to undertake to best understand how we can use this approach. So just in closing, I'd like to thank all of the partners in the task force and of course all of our funders, but most importantly, all of the individuals who've been involved in the task force through our internal team itself, our steering committee, all the other groups, but particularly all of the clinicians and consumers who've contributed so much to all of the different panels. Thanks very much.
Thank you, Julian. That was great. We could hear you and we could see the slides, so that's the first thing. Hopefully, we will have some questions that come through. So please do put them in the Q&A. We are going to have another try to connect with Lai Heng. So I think the plan is, Lai Heng, that I'm going to display your slides, which you'll be able to see on the screen, and then you'll use your audio. So can we just check that we can hear you okay?
Okay, how does that sound?
Yes, we can certainly hear you a lot clearer now. So
Okay,
I will launch I'm going to share my screen.
First of all, thank you for your patience. I realize that we don't have much time left, so I just wanted to talk to you about my reflections over the course of the last 20 months. So in the first wave, we had a lot of panicked clinicians kind of not really knowing what's going to hit Australia's shores. And initially, there weren't really that much evidence for much treatment, and I think that was the cause of the anxiety. So we use a lot of social media, for example, WhatsApp, for rapid information sharing. There was a lot of talk about whether COVID-19 was spread by aerosol. And looking back now, I think the evidence that we wanted to wait for was very slow in coming. And in the meantime, real life kind of took over and showed us some examples of aerosol spread. And there were also businesses who did some studies showing that COVID-19 did spread via aerosol, but we were not convinced. Well, most of my clinician friends were not convinced yet. And then there were also some concurrent media attention and really speculation on treatment on the media as well as normal media as well as social media. And there were all these experts that were ready to weigh in about evidence that were coming out without really a centralized repository of information that could be shared to the community. So there was a lot of anxiety among community members, and there was really a disconnect between what clinicians' view on how the pandemic was tracking and the expectations from the community. And then came the second wave. We had thought that we were starting to get over into business, back to business as usual, and then we were hit by the Delta wave. Next slide, please. And I just wanted to go on with what I had said in terms of my personal reflections. And just looking at evidence, I realized that really the evidence that we needed was sometimes lagging in real time for people who are in the front line. Some of the delays really meant that there were some people who got COVID-19 or died of COVID-19 when perhaps they didn't need to. It's speculation, but I think especially for ventilation, which is a passion of mine, if we were early adopters of the fact that COVID-19 was spread by aerosol, I think we probably would have prevented the fact that healthcare workers were 15% of the COVID-19 positive cohort in Melbourne last year. And it was one of the highest rates of healthcare workers infection in the world. Perhaps there were some late adoption of evidence that meant that we weren't prepared adequately for the Delta surge. And I wanted to show with two examples. I'll go through quickly. If you can jump to just the first case study, Steve, you might have to jump a few slides. So the first case study I wanted to talk about is about ventilation. Basically, we were really late in adopting measures in our emergency department and hospitals that would be much better in terms of decreasing transmission and infection rate in our hospitals. And we traditionally have always been not very good at managing even normal things that we see yearly, such as influenza, because many emergency departments simply do not have enough single rooms or negative pressure rooms, or up to date with PPE donning and doffing, in order to prevent transmission. We it took us probably until the WHO declared the COVID-19 as spreading through aerosol in April this year for us to make modifications to the ED. Although I was very lucky that I worked in a hospital who were receptive to what I tried to say, and we had a two negative pressure rooms put up very quickly last year. Unfortunately, we had a redevelopment, and then we had to do some other modifications after the redevelopment finished. But we haven't had very many healthcare workers infected, and I'm not saying ventilation is the be all and end all, but certainly it has helped. And the second big thing would be vaccination. If you can skip through a few slides to the second case study of vaccination. So in terms of the vaccines, there has never been vaccines that have been developed in such an amazing speed. And the COVID-19 vaccines just really was astounding in terms of showing collaboration with scientists and clinicians, and also with policymakers in rolling out the vaccines. The evidence for the vaccine was very strong. These were excellent vaccines. Even the influenza vaccine was not as good as these vaccines, but there was a lot of misinformation, especially when it came to the AstraZeneca vaccine. And when we started vaccinating frontline clinicians as well as the community, we had only a very small supply of Pfizer, and most of our supply was AstraZeneca. And unfortunately, there were a lot of negative press associated with the AstraZeneca vaccine rollout. Next slide. I just wanted to talk about a bit about communicating risk, and how the AstraZeneca vaccine just became much maligned and not created a lot of perhaps more vaccine refusal for AstraZeneca rather than vaccine hesitancy, but there was a very slow uptake of the AstraZeneca vaccine. So the blood clots that you heard most about only occurs in 4 cases in 1 million vaccines delivered, whereas actually the birth control pill that many women use had a much higher risk of blood clots at 500 to 1,200 in 1 million women. Smoking certainly caused a much higher risk of blood clots compared to AstraZeneca vaccine. Next slide, please. But in a way, it didn't matter, because if you look at the daily reporting of AstraZeneca related side effects, you would think it happens every day, but it actually did not happen every day, and the risk of death from AstraZeneca vaccines related clot complication was much lower than the risk of death from a car crash, and everyone jumps into their car and drives to the next place without even really thinking. With those 2 case studies, I would like to come to the conclusion, knowing that we don't have much time, and I'm again sorry about the IT difficulties, but I wanted to just summarize by saying that evidence has helped clinicians manage their patients for a long time, and we really appreciate having evidence guiding our practice. But perhaps the COVID-19 pandemic has just made it necessary for us to review the kinds of evidence we tend to put on a pedestal, the speed of evidence, the dissemination of evidence, and in the times of social media, who controls the evidence and how we can communicate evidence much better, so that for the next pandemic, we will be able to manage a lot better. But it's also a plug for live guidelines. The fact that many clinicians collaborate together, having meetings, and just nutting out the evidence and coming to a conclusion, some sort of consensus, has been extraordinary. I've been involved in the ASIM clinical management guidelines for COVID, and also been involved as a multidisciplinary team in looking at the AstraZeneca related thrombotic thrombocytopenia syndrome guidelines, and just being able to share the evidence with like-minded people and people from different specialties have been very, very special. So thank you, and thank you for your patience, and I hope we still have time for Q&A, and I look forward to hearing your thoughts.
Thank you, Lai Heng. I'm so sorry that it's been a bit of an ordeal to hear you this morning. We can have a couple of minutes for questions. The next session starts in half an hour, so we do have a little bit of time. So, Julian, do you want to turn your camera on? And there have been a few questions that have come in through on the chat. So I'm just trying to look at the one here. So you've answered that one, have you, Julian? Is that right? I think.
Yeah, I'm happy to speak to them as well if you want, or up to you.
Okay, so I can see the one from Zoe, is that right?
Yep.
Yeah.
There's a couple of questions about sustainability. So do you want me to talk to them?
Do that, that'd be great.
Yeah, so no, these are great questions. So thanks to Zoe and Aidan. Yeah, I think that overall, a lot of our focus is a recognition that I think the current guideline enterprise is probably not sustainable as it is now. It's incredibly resource intensive, and we need to think about sustainability, I think, in a very broad way. And that means not only looking at the inputs, but also the impacts. So, we spend a lot of time trying to look at ways to improve efficiency, so therefore reducing the unit costs of developing high quality guidelines. But of course, also looking at how we can increase impact, so that the return on any investment in guidelines is stronger. In terms of the living model itself, as I put in the chat, there's at least some preliminary data from stroke that the resources required to maintain a living guideline approximates the resources that would be required for conventional intermittent updating if you're updating every probably 4 or 5 years. So I think in terms of the total resource requirements, it depends on the particular kind of flavour or variant of a living guideline, I think, but overall it's certainly not more expensive than a conventional updating process if you're doing that at a reasonable frequency. But I think the other thing I'd probably emphasize just in this context is I think what we'll probably see over the coming years is many, many different groups now moving into living guidelines. But I think it makes absolutely no sense to do that unless you've got well-established grade methodology as the kind of DNA of your guideline. We often say living guidelines are not living opinion. This is not about just taking a kind of gobsat or, good old boy sitting around a table type methodology and updating more frequently. This is about ensuring that you can run grade methodology and keep that guideline current at the same time.
So we've got a question that's just come through. I think we've got time for one more, and then we'll have to break because the next sessions will begin in 20 minutes. So the question that's come through at the end here, what could be some priority research gaps that can be pursued on the living CPG model?
Do you want me to respond to that?
Yes, please.
I think there's an enormous number of research questions. And again, there is, if people have specific interests, I think I'd encourage you to contact Tari Turner, who's running a lot of the research program associated with living evidence and living guidelines. But I think some of the particular areas that are incredibly important are efficiency. So, you know, continuing to look at ways where we can use things like natural language processing, machine learning, crowdsourcing software, data structures, fair data, all of those things to really improve the efficiency of systematic reviews and guidelines. Implementation. So all of the implications for the implementation aspects of knowledge translation when we move into this more frequently updated model. So including the impact that has on kind of push activities, but also pull. Publications, this may not be particular interest of many people here, but continuing to evolve the way that systematic reviews and guidelines are published is an incredibly important part of scaling up this model. And I think I would just echo a statement that Karla made earlier, which was around research waste. We have to recognise that in our world now, in evidence-based practice, there is an enormous amount of research waste. I think Steve, I don't know, should I mention, but some of the works that Steve's been doing as part of his PhD has really highlighted that we're now in a world where, you know, the number of systematic reviews in a particular question is often many, many times more than the number of trials. So thinking about how we can really address that and better coordinate and use that human effort, I think is incredibly important. And then just finally, I think consumer involvement is like everything we do. I think we're still at the early stages of really understanding how best to engage with consumers. And that includes in living guidelines. You know, we've got some experience, but I think we'll look back to the point we're at now and really understand that we were only just at the beginning. I think there's much, much deeper ways that we can involve consumers in this whole endeavour.